We are now starting with the panel discussions. We will engage commissioners and an external expert in a kind of dialogue around questions. The first panel will actually deal with the overarching topic of a One Health perspective on today's health and sustainability challenges. As you listen, we encourage you to submit questions in the Q&A function at any time, and we select a few, but please be patient and also understanding if we cannot select all the questions. Each commissioner now has 5 minutes to give their submission to a specific question. The first question is, why does One Health matter for the control and prevention of emerging and re-emerging infectious diseases? From the commission, as such, as commissioner, as a very special commissioner, David, thank you so much. David will give his views, and then Wanda, as an external expert, will reply. David is a veteran epidemiologist at the London School of Hygiene and Tropical Medicine, with decades of field experience from Ebola and malaria. He has served in leadership roles at WHO, CDC, and continues to shape global infectious disease policy. And Wanda, you're the co-chair of the One Health high-level expert panel. You lead the Center for Viral Zoonosis at the University of Pretoria, and you hold several prestigious research chairs in zoonotic diseases, and you work in bat viruses, and spillover has been seminal. Over to the two of you. David, please start.
Thanks very much, Andrea. And the question you asked, does One Health matter, is certainly a question that I believe we all understand is important. One Health, as conceived by the Commission on One Health, does matter. It's necessary for the best possible control and the prevention of emerging and re-emerging infections. And if it's effective, it can prevent infectious disease outbreaks or limit their spread. And working in a One Health mode can possibly even prevent infectious organisms from becoming endemic in human or in animal populations. Working together across the human, animal, and environmental sectors in a One Health movement can also prevent the short-term strain on economies that comes from outbreaks, and can contribute to a decrease in the short and then long-term drain on economies caused by emerging infections, some of which become endemic. We know that many endemic human infections have come from the animal kingdom at some time in the past, at a time when infectious organisms breached the species barrier between animals and humans and were able to sustain transmission from human to human, or able to develop the capacity as it adapted to its new and human host. Measles is a very good example of this. Likely at some point in the past, after cattle had been domesticated and there was close contact with humans, the rinderpest virus is thought to have breached the species barrier and infected a human or humans from its cattle host. It then adapted to human populations, and today is the cause of measles that is endemic throughout the world. An intraspecies breach in the species barrier that infected domestic animals also occurred, and this was with dogs, with the rinderpest virus. It is thought that dogs did become infected with the rinderpest virus, and today it's the cause of distemper and endemic infection disease in dogs on every continent. The avian influenza, or the H5N1 epidemics today, carry some of the same risks as did rinderpest, though it has not adapted to human populations sufficiently to sustain its transmission. It has become endemic in poultry and bird populations, and possibly in cattle. The now eradicated smallpox virus was likewise thought to have originated in an animal from a pox virus in rodents, and we all know that HIV is thought to have emerged in humans as the simian immunodeficiency virus. And coronavirus 2 SARS coronavirus 2 has joined the 4 endemic human coronaviruses in humans, and all with origins in the animal kingdom, likely in bats. For molecular clock analysis of one of the endemic human coronaviruses, the OC43 coronavirus, a hypothesis has been generated that suggests the virus emerged from cattle sometime at the end of the 19th century. It caused a major high mortality influenza-like pandemic and then became endemic in humans, with its virulence controlled by population immunity. We also know that changes in temperature, as we heard earlier, and in rainfall can facilitate the emergence and reemergence of infectious organisms carried by insect vectors such as the mosquito. El Niño-related flooding in East Africa with a decrease in dry land has forced cattle infected with the Rift Valley fever virus and susceptible human populations into closer proximity. At the same time, increased breeding of the mosquito vector in floodwaters has then resulted in transmission of the virus from cattle to humans, resulting in a highly lethal outbreak of Rift Valley fever in humans. Increases in rainfall and temperature have also been cited as the causes of outbreaks of infections such as high-altitude malaria in countries such as Eswatini and Burundi. And finally, complex food systems today bring humans and animals into closer contact than ever before. And as populations increase and the demand for more food, including animal protein, also increases, intensive agriculture provides many opportunities for contamination of food, meat, fish, and vegetables with known infectious organisms, unknown infectious organisms, and organisms that are resistant to antibiotics. The Lancet One Health Commission has reviewed these and other causes of emerging and reemerging infectious diseases. And as John and Andrea have shown, the Commission has identified many ways in which the animal, human, and environmental health sectors can work together in order to better understand the root causes of emergence and to translate this understanding into policy for a more secure world. You will hear about more of these from other commissioners during today's launch. And finally, the Commission has noted that veterinarians have a much better understanding of the importance of One Health for the prevention and control of emerging and reemerging infections in animals ranging from domesticated livestock to household pets, a better understanding than those working in the human and the environmental sectors. The Lancet Commission report being launched today in one of the world's major medical journals will hopefully increase awareness that One Health matters in the human medical community. If we follow the recommendations of this report, we can move from detection of emerging infections in humans as a sentinel population to prevention of emergence at the source. And though the ways of working in animal, human, and environmental health may be different, in some instances private, in others public, and though the bottom line may differ, being either for profit or not for profit, working together in One Health can find the cost-effective solutions and innovations necessary for a more healthy and secure world. Thank you.
Over to you, Wanda.
Thank you for having me, and congratulations on this report being published and the wonderful work that you have done. So I'll build on a few points that David mentioned. He mentioned very good examples. I'm going to keep it a bit more high level and focus on prevention of spillover and primary prevention and why it's so important and how can we build on this work going forward. So it's really looking at trying to prevent pathogens from spillover from animals to humans. And we really need to shift from a reactive mindset to a proactive mindset. And that's also what the One Health approach is about. It is really proactive in preventing diseases from spilling over and preventing outbreaks and pandemics. And to do that, we can't work in silos. We can't address animal health, human health, and environmental aspects in siloed approaches. And although I think we say, you know, we're doing One Health, we're doing an approach, we're still doing this very siloed. We're bringing actors together, but the work that we do is not always really integrated and not really getting to the point where we need to look at this really holistically to reduce risk of spillover and risk of and prevention of pandemics. So it needs to bring really things together that you will probably also hear in some of the other panels that will discuss some of the aspects today, where we need to look at biosurveillance, which is testing for pathogens in different sources, animals, humans, and the environment, but also really understand infection dynamics and implementing intervention activities in the end. So what's really important for me in this discussion is that we need to understand that pathogens will not really spill over if there's not a contact interface. And that contact interface we create as humans. We create it by human activities. We're bringing animals and humans together in these interfaces, allowing these pathogens to spill over. So if we start thinking about practical interventions, it is ideal that we understand these interfaces of spillover. Lots of times we really don't know. We guess, or we try and say maybe this is what's happening, but we don't really understand these interfaces very well to act on them. So there's still a lot of research and groundwork that we need to do to really understand spillover of pathogens into humans, and also into bridging hosts where they can amplify, to really look at an approach of prevention. So what's also really important for me is context. We can't decide that something works the same in every part of the world, or even in every community, or in every situation. So we really need to think about these factors, very context specific. I saw some comments in the chat on indigenous knowledge, which is critical in a One Health approach. If we really talk about true One Health approaches, these things need to be part of these approaches that we have. And I think we also need to be mindful that we need to understand these things over time. Doing snapshots of understanding spillover and trying to prevent diseases doesn't really work. You need to have long-term engagement and long-term studies to really understand where we can do interventions that will really work. So you've heard from the two leads from this report that there's lots of things going on. You know, a pandemic agreement is now there. We talk about prevention, we talk about One Health in there. There's a lot of work that OLAP has done in this space, groundwork. There's, for instance, another Lancet Commission on prevention of pandemics at the source that's busy with their report, and the list goes on and on and on. So there's a lot of talk. And what was quite nice for me today is we align in what the messages is that we're giving through these different panels and through these initiatives. But how do we get to action? And that is really where we need to focus. We need to get to action. And that is some of the things that OLAP is also now doing in the second term. You know, why we have these plans. We have the One Health Joint Plan of Action. We have the One Health Implementation Plan. We have One Health National Plans. But what is the barriers and enablers in context-specific situations to get to implementation? And what is needed to get to this? And that is where I was quite also glad to see the recommendations of this report, because the work that OLAP is aligning with going forward is really looking at the same topics that you have in your recommendations, and looking at the enablers and barriers on a much global level with the quadripartite, and how can we get to implementation and get across these barriers and solve them, or use the enablers where we can to actually implement One Health actions across animal, human, and environmental health. I'll stop there.
Thanks a lot, David and Wanda, for your very insightful answers. Unfortunately, we have to move to the next pair. I would love to continue listening to you. The next question that will be answered by Hélène Carabin and Chadia Wannous is, how can we fix the neglect of the shared environment in the One Health discourse? Hélène, unfortunately, cannot be with us. I already mentioned this before. She is Professor of One Health and holds Canada's Tier 1 Research Chair in Epidemiology in One Health at the University of Montreal. In her research, she bridges epidemiology, social science, and Bayesian methods to understand and prevent zoonotic disease outbreaks. She will talk to us about complexity. She's a commissioner, and Chadia will reply to her. Chadia is the Global One Health Coordinator at WA, the World Organization of Animal Health, leading efforts to reduce risk of the human-animal environmental interface. And with a background in health emergencies, she previously served in different UN systems during Ebola influenza responses. So can we please play the video of Hélène, and then Chadia, you just jump in and reply to it.
Hi, my name is Hélène Carabin. I'm a professor at Université de Montréal in Canada, and I'm here to discuss with Chadia Wannous the question about what we can do to fix the issue of the neglect of the shared environment in the One Health discourse. To do that, I would like us to imagine a world where plants become resistant to antifungal treatment. So then they start dying, and it just so happened that that fungus can also infect animals, humans, get in the soil, get in water. What are we gonna do? If there are no plants anymore, if there's no corn, there's no wheat, there's no cucumber, what will animals eat? If animals cannot eat, what will humans eat? And what will we do if humans cannot have access to plants? So this is a bit of what we need to do in order to better integrate the shared environment in our discourse and in the way we think about One Health. To do this, we would need to really apply the concept of systems thinking, where something happens in one field, one domain, we really think very carefully of the impact that this may have on the other fields and the health of the rest of the living. The issue we have right now is that these system thinking concepts remain very much qualitative. They're very important to think about, but they're extremely difficult to parameterize quantitatively because we need to get information for each element of these very complex systems. So for One Health, in order to fix that issue of the neglect of the shared environment, we need to have more research and more methods to better parameterize these systems map. So that's one part. The other part, which is very, very important, would be to start develop better metrics to incorporate the impact of plant health, companion animal health, production animal health, wildlife, human health into a metric that would be able to combine all of those impacts. At the moment, as we talk about in the Lancet One Health Commission, there's no such metric in existence. So this also is another area of research that's really, really important in order to see how can we evaluate the impact of different ailments, different diseases, non-communicable diseases, infectious diseases, contaminants, on the whole One Health, in order to find the best solution that would reduce these impacts measured by that new metric. The other aspects of those metrics is that they would need to be somehow context dependent. So imagine a woman in rural Burkina Faso who loses her broiler chicken. That chicken is absolutely essential for her to feed her children during the dry season. A big industry that loses one broiler chicken in Canada or in Europe, it doesn't matter. But for that one woman, it can be the life of her child. So how do we manage to develop these metrics that can take this into account is a big challenge, and we hope that our commission will help solve this issue. So with this, I would also like us to start thinking on how to come back to an evaluation of the world that would be a bit more using the traditional knowledge of indigenous people, where humans are responsible to protect our shared environment, to make it healthy, which indirectly will protect everything that we are surrounded by. Thank you very much.
Chadia, over to you.
Thank you very much. First of all, thank you for the opportunity to contribute to this important conversation, and congratulations on launching the report very timely, as you said, giving the context that we are in now. To answer the question about how to fix the neglect of our shared environment into the One Health discourse, I agree with what Hélène said on the importance of taking the system thinking approach to this and to quantifying our success through metrics that reflect on the environment. I would also propose 3 urgent shifts for us to look at. The first one is conceptual, and then structural shift, and then political shifts. For the first one, on the conceptual shift, we need to look at One Health, as you said, in a holistic matter. Usually we focus on zoonotic disease or AMR with the environment in the background, and sometimes we look at element of the environment like wildlife as sources of risk, but this is incomplete and unsustainable view. The environment must be understood as the foundational pillar of health. If ecosystem is healthy, it can actively regulate our diseases, purify the water, stabilize our climate, and support the livelihood. When we degrade those systems, we are creating new health threats and undermining our societal resilience. This includes, of course, the unbuilt environment that we should protect, conserve, be it our forest, our wetlands, and oceans. These areas play a crucial role in maintaining the ecological balance, and we must be integrated into the One Health discourses because they are vital to our health. The second shift is about the structure. One Health is often dominated by the human health and animal health, as you said, Andrea, when we first started this conversation long time ago. But now we need to also look at the institutional mechanism to bring the environment voices into those conversations, into decision-making from the local task forces to the national, to the regional, and to the global One Health platforms. This also includes to look at the data to get the information from the environmental sectors about the climate and how this changes in the environmental factors can affect other areas of work. So we need those data on how our climate is changing, how our biodiversity is changing, and how pollution is impacting our health. However, as Hélène said, we need to have metrics for this that fully integrate the environment into the equation. And the final shift that we need is about our political scope. The integration of the environment into One Health should address the issue of policies and priorities. The short-term economic interests often outweigh the long-term planetary health. But the ecosystem degradation disproportionately affects the vulnerable population and those least responsible but most affected by those drivers. So this call for us for political will. We need to make the environmental protection a core element of health equity discourse. So our role as advocate in health, we must speak out about the climate, about the biodiversity, the sustainable land use that we have to ensure, and also the sustainable livestock production and agriculture production, because they are fundamental to our health. What the quadripartite has done to achieve those three shifts. Of course, as you said, Andrea, we have now UNEP joined the tripartite. So we are now the quadripartite collaboration for One Health to bring those environmental voices to the table. And then from there, we developed the joint plan of action, where environment is a major action tracks in this plan. But it's also integrated into all the other action tracks that talk about emerging infectious diseases, AMR, food safety, but importantly on health system strengthening and the workforce development that are needed, and how important is it to have the three sectors working hand in hand together. So in closing, I see that this One Health Lancet Commission offer us the strong platform to push for those changes. And we need more concerted actions to integrate the environment as a driving force into One Health. Thank you so much.
Thank you, Chadia. This is so beautifully said. And of course, thank you to Hélène in absentia. The environment needs to be center stage. And as you rightly mentioned, this is also a major outcome and key message of the Lancet One Health Commission report. Without further ado, I would like to come to the third question and to our two presenters. So the question is, how can we reframe health systems and non-communicable diseases from a One Health perspective? And the two speakers are Alafia Samuels and Ilona Kickbusch. Alafia, you are a chronic disease epidemiologist and a retired director of the George Alaney Chronic Disease Research Center. However, you continue advising governments and NGOs, and you bring decades of experience of NCD research and advocacy. It's a pleasure to have you. And then Ilona, it's always a pleasure to have you. We've known each other for a long, long time. You are the director of the digital transformation of 4Health Lab at the University of Geneva and co-chair of the Council of the World Health Summit. And you're also a pioneer, of course, in global health. And you helped shape key WHO initiatives like the Ottawa Charter, Healthy Cities, and also health in all policies. And you continue to do so. You're also part of the Global Preparedness Monitoring Board. Please, Alafia, you start. You're commissioner. It's been a pleasure working with you. And Ilona, you will react.
Thank you very much. Good morning, good afternoon, everyone. Let me just start a little bit talking about NCDs and One Health, because we're like the new kid on the block. Humans and other animals occupy a shared environment which is being rapidly degraded by humans. The planet has limits to what insults it can accommodate, and the resulting climate change means extreme weather is now the norm. The same social and environmental determinants of health impact the health of animals, humans, and plants, and such as exposure to pollutants, chemicals, pesticides, antibiotic overuse, air pollution, and climate change. These shared social and environmental determinants of health are the determinants of One Health. NCDs have now been given a place at the One Health table. We recognize that the risk factors for NCDs in humans are unhealthy diets, air pollution, and climate change. And food systems will be addressed more fulsomely in the next session. However, the importance of food systems to NCD risk and prevalence is significant. Obesity is a disease in its own right and a major and growing risk for premature morbidity and mortality. Small island developing states not only are at the front line of climate crisis, but also at the front line of the impact of climate on non-communicable diseases. Small island states in the Pacific have the highest prevalence of obesity and diabetes globally. And there is a lack of domestic food production given the economies of scale. And so many islands import some up to 95% of what is consumed. So trade policies from the World Trade Organization dictate free trade. So importers can import unhealthy, ultra-processed, packaged foods full of sugar, salt, and fat. They claim they are just meeting consumer demand, but this consumer demand and this new food culture has been shaped by aggressive marketing from big food and big soda. The production and processing of these foods is an insult to the environment and harmful to human health. In fact, we now see ads in the United States that say, feed your dog this new dog food, which has real food, because not even your dog should be eating ultra-processed foods. Yet the children's menu in restaurants is almost exclusively ultra-processed. We have real problems. Global warming and cardiovascular risk. It is not well recognized, I think, that climate change reduces air quality by increasing pollutants and allergens, and that this increases morbidity and mortality from asthma, stroke, coronary heart disease, especially in women and the elderly. Heat waves, of course, increase mortality, and droughts and large fires generate particles affecting lung and heart health. So we need to reframe our health systems and NCDs from a One Health perspective. The One Health approach to NCDs enables a systematic understanding and an equitable approach to addressing the shared risk factors. There are opportunities for shared solutions in the context of NCDs, where food safety and food security can be enhanced in globally, intergenerationally equitable ways while promoting health and well-being throughout the socio-ecological system for ourselves as well as the other animals we share the planet with and the wider environment. We need policy integration and multisectoral collaboration with a focus on urban planning, NCD surveillance, health system strengthening, and multisectoral collaboration. International trade regulations need to be responsive to the damage that the traded products are causing in populations of humans and other animals. There is a need to engage with the corporate actors. Some in public health will not speak to the food industry, but this is a mistake. However, when you sup with the devil, you use a long spoon. Be careful. We have to address the conflict between profit and sustainability, inclusive of robust assessments of power dynamics and cost benefits along the value chain. Regulations, legislation, and taxation are effective interventions, but in addition, the broader field of food systems governance is also integral to the debate. It is a complex issue, and it's going to require complex responses, and we have to engage with everyone. And as was said before, trying not to do it in our silos. Thank you very much.
Alafia, thanks a lot. Bold statements, much needed. Ilona, over to you. Ilona, you
You're muted.
are on mute.
I apologize. Thank you very much, Andrea, and it's hard to follow this excellent overview of the interconnectedness that we have just heard. I'm going to highlight 3 points that I'd like to share with you. And before I do that, I just want to underline what an extraordinary report this is. It was well worth waiting for. And I think it gives a message to everyone engaged in health that we cannot continue our present trajectory. I think even if we were not facing the financial crises and political crises that Richard referred to earlier on, we would have to change our approach to health because what we are doing is unsustainable in so many ways. So I think the expansion of the One Health approach to include the whole range of human health challenges and especially NCDs is absolutely critical. And I must say I'm very happy about this as well, because it underlines a key message that was at the core of health promotion since the mid-1980s, that we must address shared risk factors together and even more so address the shared determinants. And we've just heard about the many determinants ranging from trade to supermarkets to agriculture, etc. I think also it would be very helpful for the community that this wonderful slide that you had about the concept development of One Health is complemented to some extent by the thinking and the movements over the last 30 years that have tried to give the same message and have not been successful. And I think in doing that kind of analyses, for example, the socio-ecological thinking was already developed in the 1970s, and to ask ourselves why it is that we have not been able to get buy-in from policymakers to move this forward. So I think, first of all, the systems approach in health based on addressing interrelated determinants has never been more so important. Determinants, the political determinants, the social, the environmental, etc., and of course the commercial determinants. And taking forward with the One Health view that you've developed, the Health in All Policies approach, is absolutely critical. Maybe today we wouldn't do the Ottawa Charter on health promotion, but the One Health Charter on health promotion. And I think indeed an alliance between the health promotion, the planetary health, and the One Health community is something we must follow through on to move these ideas and these proposals and recommendations forward. I also think, and you hinted at it, that a systems approach needs reliable data and different type of data, and that also means that we must move away from compartmental models of epidemiology to what is called complexity epidemiology. I hope that the work of this commission can help set out a way to strengthen and operationalize complex systems thinking and intelligence in public health, bringing together the issues that we've heard from the previous speakers. And indeed, I think AI might now help us in the systematic production of knowledge on complex health problems. We have constantly avoided to really live up to the complexity. As we say in the Ottawa Charter, health is created where people live, love, work, and play. And we have not really been able to address these environments appropriately. We've already heard that we're not on track with the SDG 3 goal of 30% reduction of premature mortality related to the NCDs. And I believe that this is primarily due to the lack of action related to the commercial determinants of health. We've also neglected, in terms of policy and implementation, SDG 12, which actually speaks of responsible consumption and production. And we now see, as we have heard, an extraordinary increase of NCDs, particularly in low and middle income countries. So given the obesity crises in the health arena, the focus on food systems as a key driver and determinant of so many of the challenges we face is very appropriate, and I commend the Commission on that. Nikolai Schulz, in a wonderful book that I recommend to all of you called Land Sickness, calls on the necessity to have an understanding of the difference between the world I live in and the world I live off. And this leads us into a new type of planetary thinking. But we must also see that the tools and the technologies that can help contribute to dealing with complexity are creating new problems for the environment and for health. The boom in data centers is expected to produce about 2.5 billion metric tons of carbon dioxide equivalent emissions globally through the end of the decade, that is, by 2030. There is also a concern that the closer ties between big tech and big agriculture can lead to loss of food sovereignty and new forms of dependence on commercial drivers. Critics warn of massive issues around data sovereignty, data extraction, and cybersecurity challenges in relation to so-called smart agriculture. And so the private sector might actually be a different part of the private sector that we have not yet considered before. So in the technopolar world that we are entering, this runs to a different economics of enormous profits and loss of public value and loss of sovereignty. Thirdly, my last point, we must finally see that the growth of the health crises we face as an integral part of the planetary crises. The World Obesity Atlas from 2022 predicts that 1 billion people globally will be living with obesity by 2030. And I hope that all the fantastic work done in this One Health report and commission will allow us to make clearer that as we integrate, we do face a new dimension of a human health crisis, and that we integrate this better with the planetary crises discussion, as the concept of planetary health aims to do. And as some of the questions that were raised, that we work on trying to bring together these understandings of planetary health, One Health, health promotion, etc., into something that is policy relevant. I've suggested that we use the concept of boundaries and tipping points also in the health debate. What happens to our societies? We're saying socio-ecological approaches. What happens to our societies? Which boundaries do we cross when most of the humans in this world have one or more NCDs? When is the tipping point when this can no longer be managed? As I close, I'd like to leave you with a thought. Robert Habeck, the former German Vice Chancellor, said, "With our daily lives, we are leaving a trail of devastation throughout the earth." I hope this report, together with other related Lancet reports, will help us shape a much-needed new public health approach to address this trail of devastation. Thank you.
Thank you so much, Ilona and Alafia, for those wonderful and powerful statements, and for also charting the way forward that we need to take in our societies through the One Health lens. Without further ado, I would like to pass on now to Pamela Das, the Senior Executive Editor of The Lancet, and who has actually accompanied us for a long, long time, Pam. And without you, we would not have published that commission today. So again, a big, big thank you, dear Pam. It's been a pleasure. You're now going to handle the Q&R, and you have 15 minutes, please. Over to you, Pam.
Hey, thank you, Andrea. First of all, can I just say a warm hello to everyone, as well as keeping one eye on the webinar and presentations, of very rich and thoughtful discussions. I'm also kept my other eye on the chat, and it's just so wonderful to have so many of you from around the world, all in interesting positions and doing interesting things in your fields and in your countries. To have you all online, it's really a heartening experience for me. As Andrea said at the start, this has been a long journey. 6 years I've been working, well, only half of that time. My colleague Tamara, who began before me, and I then took over and took it to the finish line. But it's been an absolutely wonderful journey as well as the hard work and the frustration of it all. And it's so great to finally see the commission live and see all the engagement, certainly today, and I hope that will continue long after the publication is published. So we've heard some really great thoughts and discussions, and we have several sort of questions that have come up, several themes, because there's been a lot of people making comments and questions. So I'm going to try very quickly, because I know we're running over time, to just pick out a couple of the ones that stand out, or that several people have been asking, but in sort of different ways. I'd like to start with one question of how can we translate, and this is really from the chat, and I've seen various comments, how can we translate complex One Health concepts into concrete actions that resonate with communities and frontline workers? We've heard throughout this webinar, you know, very top level, high level thoughts and discussions, but now we're going to have to get really to the grassroots, those people who are at the front line and the local communities. I wondered whether the panels have thoughts on how we do that.
Well, one of the things that I have been doing in life and advocacy is trying to use the COVID pandemic to demonstrate to people what is One Health. And I think having lived through COVID, it's much easier for people to understand the concept that we are all interlinked, and even the issues of the economy and health and trade and all of these issues. So for me, that has been helpful.
Thank you, Thelma.
And maybe I would just add that I think it's very important, and we've heard it several times, that communities be involved from the start. And we've seen many different community innovations recently. We've seen in Thailand, for example, the pod activity, where farmers, backyard farmers, report when there's unusual events that are occurring in their livestock. They report that up through their community to the health system, but at the same time, there's an immediate response in the community. And that's been extended into certain African countries as well. And we know that in Indonesia and other countries, there's been the same attempt in human populations to have them report from the community level when there's something unusual that occurs. So by using 21st century digital technologies, we can change the whole way we've done activities such as surveillance. In fact, turn surveillance on turn it upside down, starting at the community level rather at the health facility or a higher level.
Great, thank you, David. I want to move on to another question, if I may. We often focus on, and this is from the chat, from Juan Lebroth and Gerata Schifero. I've actually got your names here so I can say those out. We often focus on emerging and re-emerging infectious diseases, but little is said on endemic diseases, burdens, or even chronic diseases. The priorities in a local context may be more relevant on these diseases or even NCDs, water pollution, heavy metals and food pollution, etc., than on the novel. This carries governance and financial aspects. How do we address this conundrum?
I can maybe go, I think Chadia will probably say the same as me, but in the One Health Joint Plan of Action, one of the action tracks is neglected and tropical diseases. So it's part and parcel of a One Health approach. And I think it goes back to my comment also on context specific. So if we do think about One Health actions and plans, we need to think what is important in that context and use it as an approach to address all of those issues. I mean, food security is also part of it, environment is part of it, as well as emerging and re-emerging diseases. So it's all part of the same approach that we can apply if we need to address these different issues, even non-communicable diseases, pollution that came up. It's an approach that can be applied across board. Over.
Great, thank you. Another question here from Al-Hafizi Shafir and Tessin Gul. I hope I pronounced your names properly. A very comprehensive description of One Health. Thank you to the presenters and the commissioners. The problem is, how do we tackle the challenges, financial and sustainability in the global south? Does anyone want to take that one on?
So.
Sorry, Thelma. Good for you to step up. Okay.
There's a hand from Chadia. I think she
Oh,
wants.
okay.
Oh, no. Okay. I can start. I think this issue relates to the shift in our thinking and how we think about the One Health and how we actually translate the strategies into action. And for that, we need the national level authorities to be with us on board from the start of the conversation. And this will include the financial discussions and how to secure and sustain financing for the One Health interventions. So we understand with the reliance on donors all the time, we risk that those are short-term projects, very focused on specific areas, as you said, either on zoonotic or on AMR, but we miss the whole picture where we look at the One Health as a framework that will help us to address all kinds of health challenges that we face at the interface between human, animal, and the environment. So the issue of domestic financing and looking at sustainability issues from the start of when we develop and plan our One Health interventions. Thank you.
Great. Thank you, Chadia. Another question pertaining to the future One Health workforce. This is a question from Melkamu Meles. Is there any regional or continental initiative, such as the African Union, African CDC, RU Forum, working towards a shared competency framework for One Health graduate education? There's lots of people in the chat who'd want to do that program if it's available. Is there anyone who'd like to speak to any such initiatives that are in place currently or are going to be?
Maybe I can just speak very broadly. There was a publication recently by Cabby, a book, where there's chapters in about One Health, what is the type of competencies that somebody must have if they part of a One Health workforce. We can also share those links. There's several things in the academic publication environment where people have put these frameworks forward. There's COHESA as one of the African projects across several countries in Africa where they're trying to standardize curriculums in One Health. And that's just a few. So I think there's several. It's not really a comprehensive one approach. There's different views on what those competencies should look like, depending on the specific situation that needs to be addressed. But there's definitely quite a few out there, but not currently really administered by some of these bigger bodies like Africa CDC or the African Union. So maybe there's a need for that going forward. Over.
Okay, thank you. Yeah, and I've just seen a comment in the chat actually from Renzo, who's actually going to be speaking to that very point. So thank you. I should have seen that and saved that question for then. Great. So let's just round up with one more question before we pass over to the next panel. Does One Health also acknowledge the positive roles of disease, e.g. influencing the balance between predator and prey, acting as a force of natural selection and evolution? Gosh, that's quite a scientific question there.
Or philosophical.
Or a philosophical one, yes.
Question.
depending on how you look at it. Yes, absolutely. Anyone like to have a stab at that one?
I'm looking at David. But
yes, exactly. This is right up David's street, isn't it? Or it should be.
I need to understand the question better.
So does One Health also acknowledge the positive roles of disease, e.g. influencing the balance between predator and prey, acting as a force of natural selection and evolution?
I'm not sure I can answer that question.
Yeah,
What's clear is that those organisms which can adapt themselves more rapidly and to have a shorter period of or a longer period of incubation before they're identified are more suited than are others. For example, HIV, which emerged and which had spread around the world really before it was really recognized because of its long period of incubation. So some organisms adapt themselves in a way that they're more able to survive and spread than others. And I don't know if that's a force of evolution or what causes that, but certainly mutations do play a role in transmissibility and in virulence of organisms. Not sure that answers the question, but at least it fills some time.
Thank you, David. No, I think that is a good response. Yes.
Pam, could I just come in? I tried earlier, and it's actually in
sorry.
relation to many of the other questions.
Okay,
and I just
great.
want to highlight the enormous potential of working at the local level and working particularly with cities. And this also applies to countries in Asia, to low and middle income countries where the urban population is expanding, and many of the issues that we've discussed here are particularly prominent. And so, of course, nation states are important, but we also see that a lot of innovations in health governance and around the environment and others actually comes from the urban level, comes from creative mayors who are willing to take serious decisions. Also, what David alluded to, including the digital in the epidemiology, getting people living in the city, giving responses where the problems are, where the heat zones are, where the water is going bad, etc. So I think a focus for One Health at the urban level, at the local level, working with mayors and city parliamentarians, etc., could be a very, very fruitful way forward. It's really difficult, as we saw in the pandemic negotiations, to get nation states behind One Health. But mayors do understand it, and they have to deal with their citizens every day. They don't always have the money, but they have a lot of political will, and creativity can take you quite far. Thank you.
Great, thank you, Ilona, for adding that additional point. Really important. Thanks. I'm just going to slip in one more question because it's one that I'd love to answer, actually, and it's about the power dynamics between disciplines, regions, and institutions that play in shaping the One Health narrative. What role does power dynamics between these multidisciplinary areas play, and how can we shift that power dynamic?
Take power away from the medics.
Oh,
What?
I think also understanding the bottom line is very important. Innovation must develop cost beneficial and cost effective interventions that can be used in order to prevent these infections from occurring. Vaccines, for example, could be used to prevent many infections in animals, yet they're very costly. And so if there's a way of understanding how to make more cost innovative interventions, I think that's important. I've always said the golden rule is that to understand what the bottom line is. So for some communities, it's profit, and for others, it's good health at any cost. And those are very important things to remember, because if interventions or innovations are not cost effective, they will not be used.
thanks, David. And thank you to all the panelists, and thank you to all the great questions that you asked.